Welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. According to the WHO World Report on Vision, at least 2.2 billion people around the world have vision impairment. 1 billion of these conditions, or half of them, could have been prevented or are yet to be addressed. Glaucoma is a group of eye diseases that can cause vision loss and blindness by damaging a nerve in the back of the eye called the optic nerve. It is the second leading cause of blindness globally after cataracts. Cases of glaucoma that could have been addressed are estimated by the World Health Body to be at 7.7 million. My guest, who will tell us how to save our sight, is a consultant ophthalmologist and assistant secretary of Ophthalmology Society of Nigeria, Lagos branch. She's also a HOD, or head of department of the Eye Clinic, and director of clinical services, General Hospital, Orile Agege. You're welcome to the show, Dr. Oluyemi Taiwo. Nice to see you.
Thank you.
My first and probably most obvious question is, what's the connection between glaucoma and this optic nerve at the back of the eye?
Thank you very much. The optic nerve, which is at the back of the eye, is actually the nerve that we use in seeing. And so glaucoma is a group of diseases that affect the optic nerve, which is at the back of the eye. And we have millions of these nerves at the back of the eye, which dies gradually. Of course, it gives no sign, it gives no symptoms to the patient.
They die gradually?
They die gradually, so it's not at once.
Why are they dying?
Now, because once the pressure at the back of the eye increases, the environment in which the optic nerve is located becomes unconducive. Okay. And so the nerve starts dying off gradually. And the normal intraocular pressure that is being expected is 10 to 21 millimeters of mercury. Once the pressure is actually much than that, but in some cases, the pressure could be within the normal, however, could still be very high. So there's a variant of glaucoma that we call normal tension glaucoma, that the pressure could still be normal, but it's not conducive for that optic nerve.
Okay, so you've moved somehow into the second question I was going to ask you. This group of diseases obviously includes something with high eye pressure,
yes,
and something with normal tension eye pressure. Are there other types of glaucoma besides that?
Right, so we have different types of glaucoma. We have the open angle glaucoma, we have the angle-closure glaucoma, normal glaucoma, and secondary glaucoma. And what I mean by secondary glaucoma is that glaucoma that could result from previous ocular trauma to the eye. Maybe one has had an injury to the eye in the past, or you've had any form of procedure, an insult to the eye in the past.
Okay, so that now causes glaucoma.
Yes,
by reason of that first disease.
Exactly.
You said normal glaucoma being the open angle glaucoma. Do these glaucomas have symptoms?
Unfortunately, glaucoma has no symptoms.
You don't feel anything?
You don't feel anything. So there's no pain. It's just that the vision starts going off gradually. But in some certain types of glaucoma, like the angle closure, it could come with pain, redness, watering. In some instances, vomiting. But if we look at glaucoma generally, it is symptomless. And that's why we increase the awareness that it's important for us to check our sight from time to time.
Okay, so what I'm hearing from you is that this angle closure glaucoma, which has symptoms, is not a common type.
It's not very common.
The more common one being the open angle
glaucoma,
which is symptomless.
Exactly, ma'am.
And the only way to know about it is to do a test.
Yes, exactly.
Are there any signs, whatever, maybe some time into the disease that symptoms do occur, or there's a way to know that this is a problem with a person?
All right. So by the time that we have lost a certain percentage of those nerves, let me say about 60–70%.
Oh, that's a lot.
You find out that your vision is not as sharp as what it is before. You probably could be bumping into objects. You might be having halos or rainbows around vision at that point in time. But because now it's symptomless and people do not present until about the late stage, And the aftermath is that it causes an irreversible blindness. And so the vision that has been lost, we can't regain. We can only maintain.
Even with treatment?
Even with treatment, we cannot gain what has been lost. We can maintain so that deterioration does not occur further.
Okay, so can this thing be prevented at all? Can glaucoma be prevented before it starts? Is there a method by which it can be caught before it starts?
So the only way we can do that is for us to go for a screening, for a checkup. Now, there are things that we call risk factors.
Okay.
Now, so for the risk factors, because with increasing age, from about the age of 40 years, when you start, if you have a family history of glaucoma or blindness, especially in first-degree relatives, so it's important.
First-degree relatives would be father and mother?
Father and mother.
Okay.
All right, so it's very important for people with family history of glaucoma to check their eyes very early. If you had an injury to the eye in the past, okay, an insult to the eye, is important to check the eye.
When you say insult to the eye, could it be a simple blow to the eye?
Yeah, it could be a simple blow into the eye. It could be that something hit you on the eye. It could be a cane injury. Okay, in the past, maybe you had blood in the eye, which we call ephema. So any insult into the eye in the past is important that we check our eyes from time to time. And also for some type of refractive error, short-sightedness, which we refer to as myopia, there are also risk factors to it. There are also some of the systemic or medical conditions like diabetes, hypertension. Is important. These are risk factors.
Okay, hypertension makes sense because that's a raised blood pressure,
That's a raised
which
blood
could
pressure.
also reflect in the eye.
Exactly.
But what connection does diabetes have with the eyes?
All right, so with diabetes, in the eye, those vessels, they are tiny vessels, and we could have microvascular damages. So there could be leakage of blood gradually. The leakage of blood could actually block what we refer to as the angle of the anterior chamber, and that's where the drainage takes place. So once the drainage part is being blocked, then we could have the pressure in the eye raised up.
Okay, so how do you treat somebody who presents with glaucoma in order to save whatever sight is left?
So now to treat, is it actually individualized? But the modifiable risk factor for glaucoma is the intraocular pressure. So the intraocular pressure we try to control, to bring down. Now, there are various things we could use. It could be topical medication, all right?
Like eye drops?
Like eye drops, beta blockers. There are various types of eye drops, but it depends on the presenting intraocular pressure. That's why I said it is individualized. Now, apart from that, there are also tablets that we use to treat them. We also have some other modalities of treatment, like laser, okay, like surgical means of intervention. But the best treatment would actually depend on the time of presentation of the client, affordability for the client, and also compliance. So there are things we look at before we say this is the best treatment that I'm going to offer the client presenting.
Okay, I know somebody who had glaucoma and he was given tablets. There was always this complaint of dizziness. Is that a case in which you would change the medication or modify something?
All right, so there are some drugs we give to clients. Before we give any drugs to clients, of course, we take medical history. We take drug history. Because there are some sulfur drugs that clients will react to that might be compliant with some other people. So there are some things that we take, and some systemic condition that we take pertinent, that we actually look at before I give a particular kind of drug to patient A or to client B. So, and based on the feedback that I also get from the clients, I might need to change. So we have myriads of drugs that we can use for different clients.
Now, I have a concern about eye drops. With the faking of a lot of drugs, how tight is the system to make sure that anybody who is using an eye drop doesn't end up with a substandard product? Because bear in mind that the person feels, oh, I'm using these eye drops to preserve my sight. Meanwhile, it's not the real thing, and he's still losing his sight. But because it's so slow, he doesn't know.
For that, the control measure would have to do with NAVDAC. But again, when clients instill these drops into their eye, on coming back into the hospital for checkup, there are parameters that we monitor to check if the pressure is well controlled, if the client is not losing out on vision, and if the visual field is also not deteriorating.
So do you have a method by which you check loss of visual territory?
Yes.
And how often do you ask somebody, in an active glaucoma treatment to come to the hospital?
All right, so depending on how the client is doing, it could be every 3 months, it could be every 4 months, it might be earlier than that. So, but that would depend on how my client is progressing. If I'm happy, the patient is compliant, intraocular pressure is good, I'm not losing on the fields, and if there's any problem at all, the client is coming back to the hospital to alert me, to let me know, and I can intervene as soon as I should. Then I feel a little bit relaxed to give such a person a 2 months or a 3 months, because he or she will continue to refill the drugs.
Okay.
But ideally, by annual, that's every 6 months, I would expect the client to do a central visual field, so that I can ascertain that I'm not losing out on any fields and the vision is stable. There's no form of deterioration going on in the client's eye.
So this is supposed to be a close and very tight monitoring.
Exactly.
Or else the person can actually begin to lose fields and not know he's losing fields because there are no symptoms.
Exactly.
Okay. So the World Health Assembly was saying something about, a policy trying to make patient-centered eye care, to integrate it into the health system.
Exactly.
How plausible is that in Nigeria, seeing that people see eye tests as an elitist thing, it's for the rich people? How can it actually be integrated? Do you see it as feasible?
Yes, it's very visible, and the awareness is actually increasing. Now, eye health policy is actually being integrated now, and so people can go into centers, either a primary, a secondary, or tertiary care facility to access care. Even in primary, we have eye clinic in primary health center, so that what they can manage, they refer to the secondary center. Otherwise, the secondary and the tertiary center will be bombarded with a lot. So we have trained eye personnel in primary healthcare center.
What can a primary healthcare center handle?
All right, so in primary healthcare center, we have optometrists there. They do refractive error, they treat simple eye conditions. But for glaucoma, in the primary healthcare center, they won't handle such. They will refer to the secondary center.
But can they detect?
Yeah, they can detect.
And diagnose?
Yes, they can detect and diagnose, because they've been trained to use an ophthalmoscope.
All this while, let's say it's integrated already.
Yes, ma'am.
What about the cost implication? Because if you say everybody has got to check their eyes, and one of the risk factors is being over 40, that's a whole lot of people. And I hear that black people have more of it. That's a whole lot of people having to have their eyes tested. So, in effect, everybody over 40 in this country should be checking their eyes. Twice a year, right?
Exactly.
Now, cost implications.
If we say cost implication, but if you try ignorance, it's a lot more expensive. It's a lot more expensive.
Ignorance is more expensive. That's how they always get us. Let's go on a short break. We'll come back and continue that. Please stay with us. We are going on a short break. Welcome back. We're talking about glaucoma on Health Matters on Channels Television. moalale@channelstv.com is my email address. You may write there for your questions and your contributions. You can also call 0805-468-3514. It should be showing on your screen. And you can tweet at CTV_Mary A with your questions. I understand that there's a bit of reprieve for people who want to do their eye tests at this time. Please let us into that.
Yeah. Now, this week, which is on March 6 to 12, is World Glaucoma Week. And it's a worldwide celebration, and celebrated by the World Glaucoma Association. So it's actually a week to increase awareness within the community, within the populace about glaucoma. Ophthalmology Society of Nigeria, Lagos State branch, it's organizing a town hall meeting on the 10th of March, which is Wednesday. And then there will also be opportunity for people that would like to come in for screening, same day, Sickle Cell Center, Idi Araba.
Okay.
My facility as well, Aurelia Agege General Hospital, located 3 Old Ota Road, Abeokuta Expressway.
These are free eye tests.
Free eye tests.
Does anybody, do they have to register?
No, at zero cost. They would have a card. They will have their LD vitals being done as well, because we also, I told you that there are some systemic or medical disorders associated with glaucoma as risk factors. So they will have that done, and they will have the comprehensive free eye screening done at Aurelia Agege. So, and in all the secondary and tertiary centers as well, for the glaucoma week, they would have free eye screening done, so that we can increase the awareness. They will have health talks, and then for people, during the screening, for people that we see that they actually have glaucoma, we take up their treatment from there.
Oh, that is a bonanza. Yeah. And 6 to 12.
6 to 12.
If you have somebody coming in with normal tension glaucoma, will you be able to figure that out?
Yes, because apart from the intraocular pressure, I'm going to do a dilated fundoscopy. So there are some telltale signs I'll be looking for at the back of the eye. So it's not just the intraocular pressure. And that's why I said it's the comprehensive screening.
There's some children, they say, are born with glaucoma.
Yeah.
Does that mean that they are born blind? Or is it something that can be handled?
Okay, so for children that are born with glaucoma, so there's something we call trabecal dysgenesis. So it's a congenital problem. It has to do with the angle structure. And so they are not born blind, so they can have an intervention, a surgical intervention done with topical drops. Okay. So they not necessarily, they are not going to go blind. But if nothing is done and pressure continues to shoot up, then they could.
So an operation is done to reconstruct the angle,
which we call trabeculotomy.
And then eye drops have to be given to the baby too.
Plus or minus.
Plus or minus.
Yeah.
Prefer minus. Because, a baby's angle, it seems to be shallower. You put something there and it's all pouring out.
So, and because it's a congenital problem, that is why it has to be fixed surgically.
How soon after birth do you do this?
Well, depending on when the mother presents. And then it's also...
But what's the best time?
It's best to present almost immediately, so that the necessary intervention can be done.
Are there any new things, treatment trials or new discoveries or ways of treatment for glaucoma that are ongoing? Is there anything in the pipeline?
There are a number of things in the pipeline. For example, some of the drugs that we used before, because there are different types of drugs. So what we have done now for compliance to be a lot better, we have combination drugs being introduced. We have preservative drugs being introduced as well, which reduce the stinging effect on the eyes of the clients. And rather than using about 2-3 drops at the same time, we have combination of 2 drugs in just 1 bottle.
Oh, that's a lot better.
So it improves adherence, it improves compliance on the part of the client. And also there are a number of other procedures also going on, all right, that is being done, which is good, and pressure is well controlled. So as technology advances...
Let's see if we can quickly get Ayo calling from Lagos. Are you there, Ayo?
Yes, ma'am. Good afternoon.
Good afternoon. What's your question, Ayo?
Yeah. My question is, please, doctor, if one has been in glaucoma treatment, how long would the pressure be brought down? How long? Because I was told, yes, pressure, but how long can that pressure be controlled? And is it really necessary, or rather very important, that the patient will go for a kind of surgery to correct the pressure? That's number one. My dear Alale Yusuf, madam, thank you very much. I will donate one of my charts on glaucoma chat to your TV station. I will come there one of these days.
Okay, thank you, Ayo. You probably didn't hear the whole question, but he's asking how long does the management of intraocular pressure go on for before you can stop, something like that.
All right, so management for glaucoma is a lifetime management.
Wow.
It's a lifetime.
What if the pressure goes down and it's okay?
And so the client needs to keep coming in for checkup. So the duration of checkup can actually be increased. It could be twice in a year if pressure is stable and there is no deterioration in the visual fields. But the client has to be monitored.
Okay, I can understand that for a patient you're using eye drops on.
Yeah.
But what about a patient that you do a trabectomy for?
Okay.
And you've gone to surgically alter the angle to drain out the fluids.
Okay.
Do you still have to continue with treatment and monitoring?
Yes, we have to continue with treatment and monitoring. The fact that the client have had a trabeculectomy done and intraocular pressure is a lot controlled better, we need to check the central visual fields. Okay. Also, we are blacks. At times, our surgery do fail. So I need to continue to monitor.
Okay.
And so remember, glaucoma, there is no cure. So, but I need to continue to manage the client as long as the person is still available.
Let's see if we can get a question from Emanuela. Hello, Emanuela.
Good afternoon, ma'am.
What's your question?
Okay. My question is that my husband actually have the eye problem. So we went to a hospital and they kind of screened the eyes. They said he needed glasses. He started using the glasses. I don't know if it was the glasses that escalated everything. Now the eyeballs are out.
Okay.
So I don't know.
Can you explain this phenomenon, doctor? That they said he needed glasses, her husband needed glasses, but it's like the eyeballs are bulging now.
Yeah, so
she doesn't know whether to blame it on the glasses.
Okay, well, it could and it might not be. It could be a thyroid eye disease. It might not be. Thyroid eye disease. Okay, because what she's trying to describe is like a proptosis.
Okay.
The husband eyeball bulges out. Now, it could also be that maybe there's something behind the eye, that is pushing out the eye. Okay. So except a proper examination is being done and a good history is taken, a proper examination, that's when I can actually say, or one can actually say, this is what is going on. So it's not a blame on the glasses.
Not the glasses. All right, very good. What is the work or the role of sunglasses in the treatment of glaucoma, or is there any role?
Well, sunglasses generally will protect the eye from ultraviolet A and B rays, which are harmful rays to the eye. So ideally, when we go out and it's really sunny, we need to protect our eye. So those are some of the preventive and protective measures that we can actually do. So it protects the eye.
So before people run out and go and buy sunglasses, are there sunglasses with a particular specification that people should wear? Or should people just wait for their doctor to give them the sunglasses?
I think it's better to see the doctor because the sunglasses that we actually need should block about 90% of those rays. So I think it's better. It is better to see the doctor to prescribe what you really need.
Thank you so much for that. And thank you so much for coming and shedding light on the terrible state of glaucoma. Thank you also for being there with us. Thank you, Ayo, for your question. Emanuela, this is your chance. The coming week, let your husband go for an eye checkup and know exactly what the problem is. Thank you, everybody at home, for tuning into the show. I am Mary Alale Yusuf. Have a pleasant day.